Wake up. It's the Sleep Unplugged podcast, episode 128, How to Stop Taking Sleeping Pills. I can never stop. I can never quit. Welcome, everyone, to the Sleep Unplugged podcast. My name is Chris Winter. I'm a neurologist, sleep specialist, and your host. If you're new to the Sleep Unplugged podcast family, welcome. If you're a veteran, welcome back. We're glad you're here. It's been a busy week. Last week, we did our third annual sleep gift giving guide, and it was a massive success. It was one of the most popular episodes we've released. We are closing in on 250,000 downloads, which is mind numbing. I really want to appreciate everybody supporting it. Really want to appreciate everybody supporting the companies that participated. And I want to give a special thank you to those companies as well for being a part of such a successful episode. If you are looking for ideas to round out your holiday shopping, look no further than episode 127. It has the episode has lots of ideas for gifts to give people you care about to help them sleep better. This episode, since it's the first Monday of the month, it's an Insomnia Monday, so we're doing a topic related to insomnia. If you get in touch with the show, you can do through our social media, Dr. Chris Winter Twitter, Dr. Chris Winter Bluesky, Dr. Chris Winter Instagram, which is my most popular platform. We always start our show off with comments, corrections, criticisms. This week, Rebecca asks, "Is airway dentistry bunk?" No, Rebecca, it is not bunk. There are plenty of ways you can address snoring and sleep apnea with dentistry procedures and devices. We even talked about one last week with Quiet Labs oral appliance for snoring. There are oral appliances out there to reduce sleep apnea, particularly mild to moderate sleep apnea. And, Rebecca, I think your question is prompting me to want to do an episode on airway appliances. I think that would be a great episode to talk about. I also want to do one on pajamas after getting those Lunia pajamas. They're amazing. They were part of the episode 127 as well too. Before we get going, the line in the title comes from the song "These Memories Can't Wait." I can never stop. I can never quit. Actually, "I can never stop. I can never quit" is from the Living Color version off of their 1984 album Vivid. I wore that cassette out when it came out. This was Vernon Reid's project. He was a New York-based guitarist, put together an all black, I don't even know what genre. I mean, at the time, I would have called them a little bit more like heavy rock, heavy metal, but they really weren't. They were really a genre defying group. If you listen to that first album, Cult of Personality was their big single, but one of the songs they actually covered was These Memories Can't Wait, which was off of the Talking Heads album, Fear the Darkness from 1979. It was their third album. I love this song. And as I was thinking about, okay, this is Insomnia Monday, I kind of want to I saw a patient this week that kind of stuck with me, a very difficult insomnia patient who was taking a ton of Trazodone and wanted to get off sleeping pills. And I was thinking, well, we should do an episode about coming off of sleeping pills. What's a good song about quitting sleeping pills, stopping sleeping pills? And I can hear Corey Glover, the lead singer of Living Color. I can hear him in my head. "I can never stop. I can never quit." And then it's this great break in the song, and it's a wonderful song if you listen to it. But in the Talking Heads version, it's just "I can never quit." There is no "I can never stop." He kind of added that line. So we'll put both the Living Color and Talking Heads versions of "These Memories Can't Wait" on the Spotify Sleep Unplugged music playlist. Check out Vivid if you've never heard that album. Check out Memories Can't Wait. It's a fantastic song. A couple corrections too from last week. I was talking about we have a running joke on the show about the Chelsea Hotel. Bob Dylan mentioned it in the song Sarah. Sarah was off of his 17th album, Desire. I couldn't think of the name of that album. I also mentioned that he referenced sort of reference David Bowie in a song. The song is I Contain Multitudes off of his 39th studio album, Rough and Rowdy Ways. So I just wanted to kind of clear those things up. So moving on to sleeping pills, I want to talk quickly about a patient that I saw this week who I've just thought about a lot. Young woman who has had difficulty sleeping forever. And lots of things about this patient struck me, one of which was I'll just throw out there, I mentioned at one point, I'm guessing after decades and decades of seeing sleep providers, you've had sleep studies. And interestingly, and this may be the first time in my career I think this has ever happened, she said no. She said, I suggested it to a doctor one time, and the doctor said, only sleep studies are only for people with sleep apnea. What a strange thing to say, you know? Now, listen, I don't think sleep studies are necessary for the majority of people who have insomnia. Just because you have insomnia doesn't mean you necessarily have to have a sleep study. However, I think when somebody's been struggling with insomnia for long as this patient has been, I think it's a very reasonable thing to do. So, it was something that we had kind of talked about during the visit. The other thing that was really interesting to me was at one point, you kind of asked the question, tell me about the medications that you're on, what you've you tried. And, she was sort of, wasn't entirely sure why she was taking certain medications. And she said, well, I do take Trazodone. I said, I'm guessing you take 100 milligrams at night. And she said, no, 200 milligrams. And at one point, I said something like, well, I'm guessing you didn't start at 200 milligrams. And no, she'd started at much lower, but had gradually gone up as the medications didn't work. And I think we can put work in quotation marks there. I've thought about doing an entire podcast, and maybe we will one day, an Insomnia Monday on the term work. Well, I've tried these medications, Chris. They didn't work. Well, this worked for a while, but then it stopped working. The only thing that works for me is XYZ. And work is interesting. I always ask patients, what do you mean by work? How do you define work? I think that's a very important thing to define. Is work helps you fall asleep 2 minutes faster than something than not taking it? Is work allows you to sleep because without it you wouldn't sleep? Like what is your definition of work? You have to fall asleep within 10 minutes. If it takes you longer than 10 minutes, it's not working. So that's something that only really a patient can define. So she was on a lot of medications, and whatever her definition of working was, they weren't working. Well, of course they're not working. That's why she's in the visit with me right now. I don't see a lot of patients who the CBTI is working and they're sleeping great, or they don't need anything. They just go to bed and sleep okay. And it was interesting to me at one point, she said something like, I've read your book. I listened to your podcast. I've done CBTI courses. I get it, Chris. I'm not dumb. Like, I understand everything. I rationally know everything that you say in that book is true. However, I wake up at 3 o'clock in the morning and I can't get back to sleep. And the fear comes like a punch in the face. And everything that I know goes out the window. I mean, that that was my high school wrestling career, right? I know how to get out of a single leg takedown. I know what to do if somebody is trying to, get a leg in or set up a great like I know the move. But in the middle of the match, when it's happening in real time, can you execute that? I was just talking to my son talking, we were talking about some training you do when you fly in the Navy. Remember in Officer and a Gentleman, remember that scene when you're in the airplane and it's like a little trainer cockpit and it slides down a track, it hit the water the little airplane goes underneath the water, lands on the bottom of the pool upside down, and the pilot has to remove themselves from the cockpit and swim to safety. And there's, rescue divers around. And we were talking about that. And he said something like, well, I think this is not going to be a big deal for me. I'm a swimmer. However, that might go out the window once you start and you get into it and something doesn't go quite right. You can't get the latch undone or the window's not exactly where you thought it would be. It's like managing panic in the moment. And I think a lot of I think a lot of insomnia is managing that in the moment. And around this time, soon after I was talking to this patient, I got an alert like this person from some company wants to talk to you. And so you look up the company and it's a vagal nerve stimulator or something like that. And we'll do an episode at some point on these vagal nerve stimulators. There's a bunch of them, and they're all quote FDA approved to treat insomnia. And the data is not particularly compelling. And I was thinking to myself when I saw that alert about this stimulator, how disingenuous it would be for me personally to say to somebody, I think I have your solution. It's this stimulator thing. I've seen some little knockoff versions, something like a necklace, and this little thing vibrates on your chest, and there's all kinds of different things. They're like, they're delivering electrical stimulation to a nerve. That to me is so far away from what I want to discuss with a patient who's struggling with their sleep. Hey, don't worry about it. When you wake up at 3 in the morning and everything you've tried to learn about CBTI goes out the window because your fear is through the roof, we just need to stimulate your vagal nerve more. I mean, it's just so, we can lump it all in there. Stimulators and pills and trazodone. It's all the same, isn't it? I don't want you to manage or face that fear. I don't want you to practice that. I just want you to step away from that and take the pill or take two pills or stimulate your vagal nerve or wear these things around your wrist or this thing around your head or these special sheets or this special light or this special laser. Like it's all the same, isn't it? There is a let's demand responsibility and performance from ourselves and let's try to sidestep that through something else. And one of the things I thought about after talking to this patient was this is hard. It's really hard. It's at some point, it's a decision, isn't it? It's you're gonna wake up tonight at 3 a.m. How are we going to get you to a place where you're not experiencing that fear? And one of the things I talked about was I need you to get to a place where you're running towards that experience, not away from it. That's a big differentiator, isn't it? Are you running towards it or are you running away from it? I'm going to argue that somebody who's got their insomnia figured out, but is taking 200 milligrams of trazodone and other pills at night, not necessarily running towards it. So a big part of our conversation was, okay, well, I'm taking this trazodone. I don't really, feel like it's really helping that much. And one of the things we talked about was, trazodone, you know what that's for? She didn't. I said it's FDA approved to treat depression, but off label, there's a lot of activity about trazodone as a treatment for insomnia. In fact, I think it's the most commonly prescribed drug for insomnia. So much so that the American Academy of Sleep Medicine convened a panel in 2023. We've talked about Phyllis on this uh, podcast before. Andrew Crystal, I believe, over Duke, Winkleman, Charles Moore, and who kind of wrote the book on insomnia. I can't remember some. There was a couple other people. There was like 6 or 7 people there. I was not one of the people. I was not. I was not invited. I would have voted no. So basically, they said, look, they were trying to come to a consensus on the sentence: Trazodone should never be used as a first line medication for insomnia. And they basically said, sure, but there were a lot of caveats and disagreements about what this medication really meant, you know, without it being sort of an approved drug for insomnia. Do I think it's a particularly dangerous drug? No. I just don't think it's a particularly useful one. When you look at the data as it compares to placebo, as it compares to placebo within sleep measurements, it's pretty minimal. It tops placebo by what, 13 minutes or something like that in terms of how long it takes you to fall asleep. And again, 13 minutes, okay, I'm waiting for this. If this patient said, look, Chris, it takes me 23, 25 minutes to fall asleep. I'd really like that to be closer to 12 or 14. Oh, I've got a medication for you. That's not what she was describing. That's not what anybody ever describes. It's, I can't sleep without it. I'm awake for hours and hours and hours. When you start looking at how these medications compare against placebo, particularly over a longer period of time, ignore the first check in, which is usually at week 1 or week 2. Forget that. Let's look at the long term. This woman's been on this drug for years and she's slowly going up. That's the data that I'm really interested in. And this is a confounding one too, because it is an antidepressant. If she's saying, look, Chris, I'm super depressed, then maybe the trazodone makes sense. But, what she's saying to me is, no, depression is really not a big problem for me. Anxiety, huge problem. Of course it is. We know that's a driving force for insomnia. So she basically said, look, I want to get off these drugs. If you're saying that I don't need them and they're not working, why am I taking them? That's a great question. And I think step one of getting off of a sleeping pill is to talk to the provider who's giving it to you and ask them, number one, why am I taking this drug? What is your rationale for giving me this drug? And I think within that question, you can ask, is this an FDA approved sleep aid? Those are really interesting questions because if the answer is no, I think an important question to ask is what evidence are you going on that supports this use of this medication at this dose in the way you're using it, which is slowly going up on the dose since I started taking it 4 years ago. What evidence do you have that supports the use of this drug at this dose for my chronic insomnia? That's a great discussion because a couple things are going to happen. Number one, there's going to be an enlightening conversation. Well, I'm glad you asked. There have been 17 randomized controlled studies of this drug. They generally show some degree of improvement. Half of them tended to improve sleep latency, the other didn't separate from placebo. And if you look at the group of studies on a whole about this particular medication, they tend to increase sleep time by about 7 minutes over placebo. And there is a trend towards improved sleep efficiency that was not statistically significant. Like that might I'm making that up. That's the sample answer. Or they don't know. There's I don't know. Like I sometimes give this off label. I don't really know that much about it. It seems like everybody else is doing it, so I'm doing it for you too. I think that's a great place to start the process of coming off of a pill. Why are you on it in the first place? Tell me about the evidence. Here's another one. Tell me about the evidence that this drug is going to make me perform better the next day. Okay, it increases my total sleep time by 6 minutes on average over placebo in this study that was done over 14 days. Wasn't a chronic long-term study. What is it doing in terms of my life, my job, my enjoyment of my career, my happiness when I'm around my family? Like, how is it improving any of these things, or is it? I think another important question is I know you're using this as a sleep aid, are you using it for other things in me as well too? I ask this to a lot of my patients. What is the reason the provider is giving you this drug? And is there a reason beyond sleep? I would say 90% of the time the patient really is not sure, meaning that this provider might say, yeah, I've been giving you 200 milligrams of trazodone. I give it to you at night and at that dose because I am trying to knock you out. But at the same time, I think that there is a depression that's either been diagnosed or I suspect that this is helping with too, or an underlying anxiety disorder. So this is the reason why I have a rule in my clinic. I do not mess with other people's drugs. I don't tell people stop your drug, do this. I tell them to have the conversation with their provider first. Because there may be things that I don't know. There may be things that the patient and I together are just not aware of. I mean, one of my goals when I see patients is if you're talking to another doctor about what you and I are doing together, that you know exactly what my thought process is. That when somebody, so Chris, why does Chris have you on this drug? Oh, he's got me on that drug because it's one of the four FDA approved drugs for restless leg syndrome. And we tried another one and it made me a little bit sick to my stomach. So we started this one. And he said that the maximum dose of this drug for restless leg was 4 milligrams. I'm taking two and I've been really steady with it. He likes for me to take it very consistently every night. I don't skip doses. I don't go up when I have a bad night. I don't skip it when I mean, I want them to be informed. So I think it's very important that all of that has to be done before you ever start stopping a medication. I am not going to walk somebody through the discontinuation of a medication that I'm not prescribing. I just think it's bad. Now, I think it's perfectly fine for me and that patient and that provider to have a conversation. That provider may know things about you that I don't. I'm going to guess that I know some things about sleep that your provider doesn't know. That's not a huge stretch. If it's me and the patient and the OB, and we're talking about preparations for your eventual childbirth, I'm going to know some things about your sleep and your narcolepsy and your medications. That provider is going to know a hell of a lot more about childbirth and how things affect that than I do. It is not my wheelhouse. But didn't you do an OB rotation, Chris? Didn't you deliver some babies, Chris? Yes, I did do that. Does not make me qualified to do anything related to your baby, but we can have that conversation. So, in general, once you've had that discussion with your provider and you've decided, and the provider has blessed it, that it's time for you to come off of these sleeping aids, we can have that conversation. And the conversation is generally a two-parter. There is, what is the danger of me stopping this medication? Or maybe more appropriately, what is the danger of me stopping this drug abruptly? And when we used to use, when I say we, doctors in general, I hate them, used to use benzodiazepines. And I say used to in quotes because there's a lot of doctors who use benzodiazepines now. I was just in a furniture store. I love looking around for mid-century modern kind of antique furniture. Think Mad Men, that vibe. I love that kind of stuff. Um, Even though my kids make fun of me, like you've got the most Mad Men of Mad Men bar carts, and it's a whole bunch of alcohol that never gets drunk. So it's the aesthetic that counts, right? So I was in this furniture store talking to some wonderful guy, and he was telling me about why he started the furniture store, how he loves looking around for stuff, mid-century-esque kind of stuff. And he said, "What do you do for a living?" I said, "I'm a sleep doctor." He said, "Oh my God, sleep doctor, man, I'd love to talk to you." And he said, "My doctor finally got me worked out. I just take a bunch of temazepam every night." And he laughed. I never know what to say at that point. Like, am I going to sit down in this furniture shop and get into it with a guy I met five minutes ago who I'm trying like crazy for him to sell me this super cool, guitar pick, coffee table or Ames chair, Sputnik light fixture. I don't, it's not an easy conversation. there's no real middle ground. So you just kind of like, oh, okay, well, if you ever, need some help, come to the Commonwealth of Virginia. I'm happy to see you, right? So temazepam is sort of a benzodiazepine. Think Valium, think old sedatives. These medications you do need to be careful with. If you've been taking temazepam, lorazepam, alprazolam, clonazepam for a long period of time, you do not want to suddenly discontinue that medication. You can cause a lot of problems in that withdrawal. So for those types of medications, you can come off of them. We just want to do it slowly. And what I tell patients is this: you don't get prize money for doing it fast. If somebody says, "Look, I just want a cold turkey off all this stuff, Chris. I've read your book. I'm super motivated. I believe, I believe." I, I always tell patients, if I mean, this is your life, but why? Why rip the Band-Aid off when you don't have to? So to me, for the benzodiazepine class, we want to be very careful. So that leads me to the other classes of medications. Can you abruptly stop them? Well, yes, you can stop taking them tonight if you want to, but I think you're opening yourself up to a lot of unnecessary difficulties. And I promise you, pick a drug, go to Reddit, type in, what happens if I suddenly discontinue drug blank? You're going to get a slew of threads of some really heinous stuff that went on. Now, that could be anything. You could be taking a Flintstone vitamin every day for a year and you suddenly stop taking your Flintstone. I promise you, there's a thread about the sudden discontinuation of Flint. Do they still make Flintstone vitamins? I might be really dating myself with that reference. God damn, I love Flintstone vitamins. Um, Nothing like making a vitamin taste like candy. I mean, talk about Mad Men. My guess is Flintstone vitamin. I'm going to look this up for the next episode. I'm guessing the Flintstone vitamin happened during that Mad Men era of advertising, and man, it was successful, wasn't it? Anyway, so I don't think any drug should be abruptly discontinued. Even Trazodone can cause all kinds of weird, sweaty, sweating, and I think priapism is one of them, a clitoral engorgement, problems, the painful clitoral engorgement. Nobody wants this. So let's not multiply your problem with insomnia with these kind of crazy side effects. Just come off of them slowly. And there's, a bunch of studies that basically say, look, the best way to come off of sleeping pills is sort of a gradual dose reduction or a tapering. Some people recommend with a substitute medication, other without. Again, the substitute medication rings a little hollow to me. I'm not opposed to it, but here, stop taking drug X to make sure you fall asleep every night and start taking, you know, you can do it. It's not my style, but if somebody says, "Look, Chris, I am freaking out. I want to do this, but I'm freaking out not having my medication," then we can substitute something else and then we'll work on that later down the line. But I'll tell you that that's not typically my style. It just seems to me like it's that mental construction of you need a pill to fall asleep when in fact you don't. And if you listen to this podcast, we don't need pills to fall asleep. Is our sleep going to be wonderful the first night we stop taking the sleeping pill? No. And now we get back to the word work. Um, and one of the most common things I hear when I bring the subject up with a patient, hey, let's maybe think about stopping your sleeping pill. Oh, no, no, no. I tried it 2 years ago and it didn't work. I had a guy, man, I had a difficult insomnia patient a few months ago, and he showed up ready to fight. The whole thing was precipitated by the fact that his primary care doctor was like, "Look, I'm not writing you these sleeping pills anymore. It's just an insane amount." And he was angry. The doctor said, "Look, I'm not leaving you out in the cold. I'm going to send you to see Chris. Thank you. Appreciate that referral. I'm going to send you to see Chris and let him take care of it." And man, I don't remember what this guy's occupation was. I'm guessing he was a lawyer because the whole thing felt like a fucking cross-examination. You know what I mean? Like, well, now wait a minute. You just said, let me read back here. Let me read back through my notes here. Okay, you said 7 minutes ago, and I quote, sleeping pills will not kill you. Like it was that kind of thing. Like trying to catch me in some loop of logic or, whatever. And I was like, look, I'm not writing you all these sleeping pills because they're not necessary. You don't need these sleeping pills to fall asleep. So let's work our way through this problem. And he just wasn't that interested in doing it. Now, the woman I was just talking to a couple days ago, very interested, scared to death, but very interested. So to me, tapering makes sense. I also usually throw in a little rule that, look, if you've got something going on here, we can taper it. We can also do something where you get 4 pills for the upcoming week, not 7, but 4. And you get to choose when you take them. You got a big day on Wednesday, meeting with a client, and you're worried about, well, if I don't sleep well the night before on Tuesday, I'll have a terrible client meeting. So I want to take it. It's fine. If in a few months you're saying to me, Chris, I'm taking 4 sleeping pills a week versus one every night, and I'm doing okay, great. Maybe we can move you to 3 or 2 a month. Now we're getting close to the point where you're kind of taking the sleeping pills the way they were intended. If somebody says to me, Chris, I take a sleeping pill, I don't know, 3 or 4 times a year. I don't have a problem with that. I mean, you don't need to if you don't. I mean, I don't, but if you want to, that's fine. This is got bigger fish to fry than somebody taking 4 sleeping pills a year. So, you know, we got some wiggle room here. Chris, I'm down to, one a week. Sometimes I'll go a week without taking it. How are you doing? Are you alive? Do you sleep? Like now you're starting to create a foundation that doesn't exist with our patient. And that foundation is I have nights where I sleep well and I'm fine. I need something else to happen in that time period. I need you to have nights where you don't sleep well and you're fine. That to me is a big hurdle with stopping the sleeping pills. Because going back to what I was saying before, I lost my train of thought. Chris, I tried stopping the sleeping pills. It didn't work. What do you mean by that? It's always this story. I decided to get off of them. I stopped the sleeping pills. I went 7 days without sleeping or something insane. So it was like I had to go back on them because I wasn't sleeping without them. Maybe, maybe you went 7 days. Were you manic? Were you concerning your family? A lot of times, if you can get the family in there and ask him, back when he stopped the sleeping pills and he didn't sleep for a week, they'll stop you right there. What do you mean didn't sleep for a week? Sweetheart, you had a rough spot, but you didn't go a week without sleeping. In fact, remember, you fell asleep trying to help. This was a true story, trying to help your daughter put together a dollhouse. So in the middle of putting together a dollhouse, he fell asleep. A, what does that prove? Proves that you can fall asleep. B, proves you can fall asleep while in the living room with lights on, putting together a dollhouse. Isn't sleep amazing, right? Kind of forgot about that part. Well, I didn't sleep well, or, I didn't tell you how bad I was, whatever. So get ready because when you stop the sleeping pills, this is going to happen. And now we're kind of back to how does that make you feel? Let's stop your sleeping pills. Okay, you've weaned off of them, or you decide to not take one tonight. What's going to happen when you get into bed and an hour has passed and you haven't fallen asleep? That's where the cognitive behavioral therapy has to be in place first. If you're out there and you haven't read my book or Jade's book or some good book about cognitive behavioral therapy and insomnia, Charles Morin's book, you're just asking for trouble. You don't have the tools right. You're stepping in to the batter's box with a professional baseball player who throws 97 and you don't play baseball. You don't have the tools to be in that position. We've got to get you to the point where you've got some basic foundational knowledge to allow you to complete this. So If you're thinking about coming off of a sleeping pill, you have the discussion with your doctor. You come up with a tapering schedule, but by God, you've got to start the cognitive behavioral therapy for your insomnia right away. Find somebody you trust, find somebody you ally with, and educate yourself. And if you're like the woman who says, look, I've been through all the courses, I've read all of the books, you may want to start thinking about is there an underlying anxiety that you're dealing with now? Because she even said it. Like, I've read it all, I know it all, but at 3 o'clock in the morning when I can't sleep, I am paralyzed by fear. We might be a little bit outside of a purely sleep driven disorder and maybe more in sort of a mood disorder category. So I think it's really important that you ally with people. And it's been shown in a lot of clinical studies that when you look at individuals who are successful weaning off of sleeping pills, they've got clinical support. They've got clinical meetings that, I mean, these are the patients that we'll see every week. I don't mind. You want to talk every week? That's fine. You're not going to be talking to me every week for the rest of your life. I can almost promise you that. But in those early stages, we might need to debrief about Sunday night, which was rotten. Chris, I felt very confident. I didn't take the pill. I stayed up a little bit later, which I always think is a good idea. Let's not go to bed early. Let's stay up late. Check out Dune Prophecy and binge those first three episodes. Go to bed at 1 a.m. instead of at 10 o'clock. I did all the things you said, and I was so confident, and I thought I was about ready to fall asleep, and then I woke up and I couldn't. So to me, part of that cognitive behavioral therapy, part of that plan for coming off a sleeping pill is what are you going to do when sleep doesn't happen the way you want it to? Because it's not. Let's go ahead and plan on the fact it's not. You're going to take a while to fall asleep, or you're going to fall asleep, and 2 hours later, you're going to wake up and you're going to really struggle to get back to sleep, and you may not. So, what's the plan? You're going to read a book, do some homework, check emails. You got a TV show you want to watch, you want to clean some part of your house, exercise. I tell people, look, if you want to get up at 7 a.m., but you wake up at 4:30 and can't get back to sleep, maybe just start your day. It's okay. I mean, we've talked about resting before. Rest if you want to, but maybe just start your day. And then you're not allowed to go to bed until our predisposed bedtime. That's why sleep schedule becomes really important when you're coming off of sleeping pills. Do you have that in place? Because what I can't have you do is have a terrible Sunday night, get home from work, and take a nap or skip work. Well, Chris, I had a terrible night without my sleeping pills. I didn't sleep at all, so I just skipped work. What'd you do at home? I slept. Can't do that. Your brain's got to pay a little price there. So, allying with a sleep professional when you're coming off of your sleeping pills is extremely important. Scheduling, cognitive therapy, managing other medications. Are you exercising? How is your mood? It can be a real team effort. And the thing I'm going to tell you right now, it's going to take time. It's going to take time. And the fact that you're struggling without the pill is not a sign that the pill is necessary. If that were the case, we would never take away a kid's blanket and teddy bear where they get to be a certain age. Remember that day? I remember that day. My mother and I were sitting on the steps, and she said, I called my blanket Hiya. Oh, God. I have no idea what that even means, but my blanket was called Hiya. And I remember she said, you're getting a little old now for Hiya, which was disgusting at this point. Pilled, gray. It was just an awful looking blanket. You're getting a little old to be sleeping with a Hiya, and we're going to take it away. I remember that. It was not, there was no nonchalant response there. It was like, what? Like this, I'm certain my sleep was not great for a period of time. That is not an indication that HEIs are FDA approved to improve sleep quality. It was an emotional anxiety fear response. I've never done this without HEI, you know, of course. So you're going to have to manage that. And that's where allying with somebody is extremely important. So find a sleep professional out there who can help give you the support you need to come off sleeping pills because you can. Everybody can come off of sleeping pills, in my opinion. I see it all the time. And one of the most rewarding things that I see in my clinic is when somebody says to me, A, I don't even know why I was on those to begin with. And B, my God, Chris, I sleep so much better off of these pills than I ever did on them. So if you're battling sleeping pill or sleeping pill addiction right now, I feel for you. I hope you can find a professional out there that can help you move away, but it all starts with education. And that's why you're here. You're trying to get good sleep information because that is the foundation for anyone to come off of sleeping pills. So that's it. Tell me about your sleeping pill story. I'd love to hear about it. Dr. Chris Winter Twitter, Dr. Chris Winter Instagram. For more information, you can check out the American Academy of Sleep Medicine. They have a lot of reference and material for people who are looking for help. Talk to your primary care doctor, get a referral to a licensed behavioral sleep therapist, and let the process unfold. And give yourself time, give yourself patience and grace because it will take a little bit of time. This is not an easy process, but it can be done. That's it. Thanks for listening to the podcast. You can again reach us, Dr. Chris Winter, Twitter, Instagram, TikTok, and until next week, sleep well.